Today we'll be discussing about RIRS and ECRIS. RIRS का नाम तो आप में से काफी लोगों ने सुना होगा. ECRIS का नाम शायद कुछ लोगों ने ना सुना हो, कुछ ना सुना हो. फैज को शायद पता हो क्या होता है ECRIS. Do you know फैज what is ECRIS? No sir. कोई यूं बताएं बेटा. Endoscopic combined retrograde intolerance. Very good. So both of these are modalities to manage the stone disease, right? So the thing is this, we were discussing that in the timeline, things have changed over the period of that time. Like previously, people were doing parallel thoracic and incising wire flying and removing the stone. Then comes the role of PCNL, followed by now we are moving towards RIRS, retrograde surgery, because they don't even like this 1 centimeter hole in the kidney. And that is quite right, because ultimately you are damaging the parenchyma of the kidney while doing these surgeries. So, Dr. Hamza, please start with the pitch.
Assalamu alaikum, everyone. As Dr. Shah said, today the topic of discussion is RIRS and endoscopic combined retrograde intracranial surgery. So, starting with the timeline of the discovery of the flexible ureteroscope, it first started in 1964 and it was reported by Marshall, the first flexible ureteroscopy. And following that, there were many advancements in this. Like in 1980s, there was first time invention of working channel with the flexible URS as well. Working channel, irrigation, active and passive deflection was established in 1980. Coming to forward in 2008, that was the digital era, the first clinical report of digital ureteroscope, and following that in 2008, there was the first report of robotic flexible URS. And coming downwards, there was further new models, new discoveries that were more commercially and easily available, and that was economically cheaper as well. And these models were LithoView and Usco. And the latest device that was invented in 2023, that was LithoView Elite, and it got FDA approval as well, and it now gives us real-time pressure monitoring in the pelvis. So this is a picture of a flexible ureteroscope. This is how it looks. It has an optical unit, and which is the part of a handle, and an operation channel, and a lever mechanism. And at the end, there is a deflection mechanism. So the whole length of the scope is almost 65 centimeter, but it's variable. Different models have different length. We will come towards the length in the coming slides, and the diameter is also different. And the average, the most common diameter is 3 millimeter. So the lighting system is LED in the most of the models, and with the source integrated in the handle, as I said, and the working length ranges from 65 centimeter to 98 centimeter, and the deflection angle ranges between 270 to 280 degree. Well, the ureteroscope has basically flexible URS has 3 kind of movements, and these movements are flexion and extension that you can control with your thumb. And this ranges from 270 to 280. So one movement is like this. This is a straight flexible URS. One movement deflection angle is this, backward 270 80 degree, and the one movement is this 280 degree. And in addition to this, the other movement is the forward and the back movement. And the third movement is you can move the scope laterally and the medially with your hand. So these are the 3 maneuvers that are required to operate a flexible URS. The weight of the different models ranges from 104 to 940 grams, and the diameter of the shaft and the tip ranges from 7.5 French oblique to 9 French. And the working channels, this is almost same in every model, and this is 3.6 French working channel. Of note is the development of single-use semi-rigid ureteroscope, such as the name of the model is Revo DURS. This is a single-use semi-rigid ureteroscope. It has an outer diameter of 9 French, and the special feature is that it houses 3 channels consisting of an outflow channel, a working channel for accessories, and a dedicated channel for the laser fiber. So, single-use or reusable ureteroscopes. There are some benefit of the single-use ureteroscopes is that it has a favorable physical character, including modifications. It has a low weight, and that translates into certain ergonomics that are advantageous for the surgeon. But if we look at the clinical outcomes, like the stone-free rates, the infectious complications, they are similar. No one is superior, either a single-use scope, disposable scope, or a reusable. So the accessories that are used with the flexible URS, we will discuss these in coming slides. And the first thing we use is guide wire. The guide wire should have a three characters that are of a good wire is that the tip should be flexible, it should have a low friction, and the shaft should be rigid. Ideally, two guide wires, one 50 centimeter long and 0.035 or 0.03 inch diameter guide wires should be used. One should be a safety wire and the one should be working wire. And the distal tip must be flexible. It should be atraumatic. We all know the characters of an ideal guide wire, and its length varies from 3 centimeter to 15 centimeter. And difficult ureteral access can be negotiated at times with a smaller diameter wire like 0.025 to 0.028 French. So the next thing is ureteral catheter. As we do with the semi-rigid ureteroscope, we place 5 to 6 French open tip ureteral catheter for an RPG image and for positioning the guide wire in the ureter or to obtain urine sample from the pelvic glacial system. We do routinely for getting an RPG image. So the next thing is ureteral access sheath. The access sheath is a two-piece device, hydrophilic device, the sheath and the internal diameter. The inside is the dilator, and the rest of the thing is funnel. When we place the sheath, we remove the diameter and the funnel remains inside. And it comes in various diameters ranging from 9.5 to 14 French internal diameter and 11.5 to 7.5 French external diameter. So different models, different diameters, internal and external, and the length also ranges from 20 to 55 centimeter. So the benefit of placing a ureteral access sheath is that it allows rapid entry and exit in the system, and it is a hypothesis that it allows to reduce intrarenal pressure by facilitating the flow of fluids out of the collecting system. But there are certain disadvantages of using the ureteral access sheath, like damage to the ureter when we place the ureteral access sheath. And there are different studies. Some support the use of ureteral access sheath and some does not. So the next thing is stone extraction devices, and these include stone graspers, baskets, and forceps. One of the commonly used device is Nitty-Roll baskets that are now standard devices for stone retrieval. And they also help us placing the stone from one calyx to the other calyx to easily fragment the stone like the lower calyx stones. And the diameter ranges from 1.5 French to 2.5 French, and they are flexible and they are designed not to damage the scope or the intrarenal system. The next thing is the graspers. They have 3 or 4 prongs that allow the impacted stone to be extracted. And the third thing is biopsy forceps to take biopsy of the tumors or the urothelial mucosa out from the ureter. And now coming towards the laser, there are different types of lasers that are available for the flexible URS. And now the standard is Holmium YAG laser. This is the gold standard now for use with the flexible URS, and it delivers pulsatile energy. It allows us intracorporal lithotripsy, management of ureteral strictures, as well as management of urothelial tumors. The smaller diameter fiber delivers less energy, but it allows the deflection of the scope. While the larger diameter fibers, they restrict scope deflection, and but they give more power. So there is a red beam at the end which shows us where the fiber is directed or where the target is. So how to position the patient and how to gain access. Like we routinely do, we make sure we have a urine analysis and we have given the prophylactic antibiotics. Typically, dorsal lithotomy position is made and we ensure that the pressure points are protected. And then fluoroscopy should be available, radiation single should be placed outside the OR, and we perform a cystoscopy to assess the position and the size of the UO and to help insert a guide wire into the renal pelvis under fluoroscopy guidance. We routinely do this, and then we perform an RPG via a ureteral access together under fluoroscopy to visualize the ureter and the interrenal anatomy or the pathology. For all ureteroscopic procedures, a safety wire which provides access to the renal pelvis should be placed and kept secured at all times. We don't do this, we just place a single wire. Under fluoroscopy, flexible URS or the access sheet, if it is being used, is then passed over a second working wire.
So, this slide is very important for my new colleagues. Whenever someone asks you in exam how to do a URS, it's very common that people start with, I'll put take a URS of like 6 or 7.5, and then while you try to go to the panel, and then I will try to calculate the PU and then put like Ureter. So this is not the standard way of performing a URS. There is a written standard way of doing the URS, and there are some pre-requisites as mentioned that you need a culture, you need to have antibiotic, you know how to position the patient, what type of anesthesia is required, and then the procedure start with the cystoscope. You have to visualize the unit star, you have to visualize the unit qualifiers, and then you are going to perform a contrast study in the form of RPG to assess the anatomy of the system before going with the scope. So you have to tell the examiner all these things. And then another important thing about the safety guideline. This is very important at your level. I've seen most of the people when call for help during the procedure are not aware of these things. Right? If you are unable to negotiate your scope into the ureter, the ideal thing is to put a wire first and then go again secondary to the wire. It will be easier because most of the time the ureter is tortuous for having a difficult course to negotiate directly with a ureter in a scope. So it's better to put a safety guide right there. It will straighten up your ureter and you will be easily doing this URS thing. So these are the set and the standard protocols. If you start following this protocol at this level, then you will learn things.
So after cystoscopy, a safety guide wire you have placed and routine ureteric dilatation is not necessary. But if the ureter is narrow, you can do it with the help of
how to do the RPG. RPG कैसे करते हैं? भाई RPG को सही करते ही नहीं. कैसे करते हैं? तो RPG में सिर्फ pelvic calyceal anatomy. You have to put the ureteric catheter at U and then put some contrast 1 or 2 mm and see the lower ureter and mid ureter. Then you have to put the guide wire in into the pelvic calyceal system and put the ureteric catheter up to the mid ureter, and then put 2 to 3 ml of contrast and then see the upper ureter and pelvic calyceal. जब भी आप RPG करें, usually मैं RPG देखता हूँ वो जो है वो सिर्फ pelvic calyceal system को दिखाते हैं और उसके बाद और 5 to 10 ml of contrast से ज़्यादा नहीं डालते, ठीक है?
And I will try to put this contrast yourself, not by your system, because it has to be gentle.
That is important. Gentleness is important, and the CC of the contrast is also important. Because when you push larger amount of contrast, then there are problems of sepsis. So Dr. Nandil is right that
there is a method for on PGS.
For flexible URS, you should not do the starting. You should go in without ureteral access sheet, and you have to visualize with the flexible URS what is the ureter. And then you can pass the other guide wire, and then you pass the ureteral access sheet, and then go with the ureteral access sheet. समझ गए? Flexible URS में जरूरी नहीं कि हम आरटीपी करें. हम flexible URS भी डायरेक्टली ले जा सकते हैं ऊपर तक और नेगोशिएट कर सकते हैं कि जो flexible URS बहुत ही नेचर साइज के आ रहे हैं. तो उसमें जो है आप पहले फ्लेक्सिबल यूआरएस गाइड वायर एक गाइड वायर सेफ्टी गाइड वायर डालें, तो इसके बाद फ्लेक्सिबल यूआरएस ले जाएं ऊपर तक पूरा पेल्विक सिस्टम और जो है यूरेटर देख लें और फिर उसके बाद
handling of the flexible URS. So the handle of the flexible URS is held with the dominant hand. With your right hand, you hold the handle of the screw, and the tip is held with the non-dominant hand. So the scope should be kept straight without any distal tip deflection, and then it is inserted into the interrenal collecting system over the working guide wire. So in the left hand, you should have the tip. You would be standing perpendicular to the patient, and with the left hand you have the tip, and with the right hand you have the handle of the scope, and you can control the deflection with the help of your thumb. And the working wire is then withdrawn, and the cold light cable, camera, and the irrigation system is attached to the handle. This is a video demonstration of the flexible URS.
For this particular video, we need to focus on the maneuvering of the hand of the surgeon performing the surgery. This is just to make you guys aware. This is quite different from the semi-rigid URS you people are doing here. This is not something that I am applying force and then maneuvering with just like rotating my semi-rigid and then advancing into the ureter. This particular thing is very different whenever someone is used to do semi-rigid and then is handling this type of flexible URS. So this blue color now was basically deflection. Now with Dr. Hamza was telling me the start of the presentation. So that is like 270 or 280 deflection is possible into different ways, deflection and extension. And if you look at the hand of the surgeon with the other hand, he is advancing the sheath inside or it will drawn outside. But with this hand, he is just doing it like this. So this has to be learned. This is a learning curve. Right.
You need to put the upper end of the ureteral access sheet in flexible URS.
Yes.
कहाँ डालना होता है? बोलो ना आपको बोलते हैं.
कहाँ तक छोटा आ रहा है एक्सेस शीट को?
pelvis तक ले जाएंगे नहीं?
नहीं.
अब की बात. कहीं भी बोलते हैं. कहाँ कहीं आगे सीधा क्या?
सर मैं ये करूँ. So the answer to Dr. Tanvir question possible you can site यहाँ पे आपको उसको छोड़ना चाहिए. तो यहाँ this is a very important step. But basically surgeon is doing is basically the stone was in the lower calyx and he's migrating the stone to the upper calyx. Can anybody tell me why is it so? Why he is migrating the stone? He can just take the stone down there in the lower calyx. If he got a flexible URS, he got a major available. Why he is migrating the stone to the upper calyx or preferably in the pelvis if it's in at least visible? And now it's experimenting the stone. Any good reason for doing so? So you, Dr. Ali is saying that there will be problem with the fragmentation removal. So he is using a laser, and if you put a laser on a testing setting, there will be no problem with the irrigation and the removal of the debris of the residual stone.
बताओ ना कैसे 2024 में पेपर है कैसे रिमूव होता है यार what is the modification in the ureteral axis sheet the weight and remove the stone
Yeah.
क्या है वो
Sorry? Speak down, please. Mic पे बोलो भाई. Mic दे दो. So, retrieval basket choose कर सकते हैं आप. Right. Got it. So my question is, why is it important to put a stone at a more accessible position before starting the fragmentation? So there are 2 to 3 reasons for doing so. Observe it as well.
So one reason is that when the stone is in the lower calyx and you have bent the flexible URS, there can be damage to the laser fiber, and as well as the laser would be less efficacious. There will be damage to the laser fiber as well, and there could be damage to the scope, deflection angle scope as well. So the laser is not efficacious as well in the lower calyx. When you have bent it to the maximum, you can damage the deflection angle of the scope as well. So it is better to retrieve the stone from the lower calyx with the help of forceps or a basket to the upper calyx and then fragment it.
And another important point is that if the stone is in the lower calyx and you have somehow able to visualize it and then start fragmenting, it won't be possible for every time you go and exactly go to that angle, because this is a, like, if you look at the indication of RIRS or flexible URS, we are dealing with a stone of like 1 centimeter or 1.5 centimeter. You might need repeated access to that particular area to fragment it, to remove it, the debris or things like this. So for that, you need the stone to be at better accessible location in the kidney to deal with. And this particular, and when you use it in a deflected mode, this URS and the laser fiber, usually we use like 200 micron or 350 micron laser fibers. They said that it has a less efficiency in fragmenting the stone when it is deflected, like when it is curved. So this is another thing. So we consider that we should move the stone towards a more accessible site in the kidney before starting the fragmentation.
जो मैंने क्वेश्चन पूछा था उसका आंसर ये है कि we have to put the upper end of the ureteral axis sheet 2 centimeter below to the PUJ. 2 centimeter below रखते हैं PUJ, क्योंकि अगर आप PUJ पे रखते हैं तो you can damage the PUJ as well. So there is a chance of PUJO if you put the ureteral axis sheet at PUJ. So you have to put the upper end of the ureteral axis sheet 2 centimeter below to the PUJ. ठीक है?
So as we have discussed this slide, management of kidney stone other than the lower pole calculi, we have discussed.
आपने बताया what is the modification of ureteral axis sheet they have done, and it can help to remove the fragments from the pelvic image.
Now it has.
What is this?
What is
this? DISS.
It is an abbreviation of 3 things. One is irrigation channel. I stands for irrigation channel.
This is direct scope suction. If you suck the stone through a scope through any channel, and then this is this. यानी आप क्या करते हैं कि suck करते हैं. इन्होंने modification की है ureteral axis sheet की. उसमें एक channel है जहाँ से आप suck करते हैं. तो अगर आप manually suck करें, this is this DISS. और fan क्या है? Flexible and navigable suction ureteral axis. So fan is the modification of the ureteral axis sheet. अब fan में क्या करते हैं कि we connect the low pressure suction to the ureteral axis sheet. Exactly. So we can remove the small dust particle from the while doing the dusting process. सही है? तो क्या है modification? जल्दी बता दो. What is this? बोलो ना, बोलो यार. What is this?
direct in the scope section.
Or the manual section. So what is FAN? Flexible and section of the.
So, as Dr. Chandy is just mentioning about this particular concept, so currently, if we talk about the approval level, we are at the level of view that you mentioned, I guess, first slide. So what they have done, they have attached like transducer with the access sheet, so we can have like real-time monitoring of intrarenal pelvic pressure. This is the most important aspect while doing any intrarenal surgery or URS, because this is how you are going to complicate the things. So for using suction or for stopping the irrigation channel or lowering down your water, for everything you need a real-time monitoring of your intrarenal pelvic pressure, so you can adjust your setting accordingly, prevent these complications. So things are moving at very fast pace. You might see like few more advancements before paying your exam. So you must be aware and must read these things frequently.
So as we have discussed in detail, how to displace the stone in a favorable pelvis and then fragment it. So one thing is that if a stone cannot be displaced from the lower pole calyx, it is fragmented in situ using a smaller laser fiber. And for the introduction of the laser fiber, the scope must always be kept straight, as I said earlier, undeflected, and scope deflection is only started after the fiber is at the tip of the endoscope.
So for this particular thing that you mentioned, for with a smaller like wavelength, laser fiber, easier to have some deflection. If you use a like 560 micron or 400 micron, it will be difficult to deflect. So for that reason, if you are using a greater mobility or a greater deflection for the lower galaxies, you must be using a smaller laser fiber. Another important aspect is you have to put the fiber after you have visualized the stone and you are at the correct position, your flexible URS, then only you can put the stone. With the stone, you can put the laser fiber. If you use these manipulations or deflections while your laser fiber is inside the flexible, then it might get damaged.
So, I want to say something here.
Yes, sir, sure.
Whatever you are saying about making the stone coming to a position which is like a comfortable position for your instrument to work upon it. Now, maybe that's a classical teaching, but nowadays it has been challenged by other techniques. For instance, Moses technology has challenged it. You don't have to grab the stone, you don't have to use basket stone, other stone retrieval objects, just to make the stone static, and then you do away with something called retropulsion. You create a bubble, and that bubble can be created by many things. For instance, the low cost addition is just introduction of a jelly that we use. So with a lot of jelly that is being used, now that jelly creates a kind of web, and in that web of jelly, this stone doesn't move. So you have to work in it, and that is water soluble, so it dissolves on its own. With the Moses technology, what is gifted is something which is manipulation of the pulse. So if you see of these newer fibers, these laser fibers, they are worked on different say manipulations. So ऐसा नहीं कि आपने एक बार सेट कर दी उसकी frequency आप उसी पे चल रहे हैं. You can the frequency of pulse. You can not only take the frequency of pulse but also duration of pulse. So frequency is something different, duration is something, and that gives pulse. So within the cavity, the stone is sort of in a static position in which you can do away with it with laser.
So moving to the next slide. One method of prevention of stone fragment accumulation in the lower calyx is to form a blood clot. 5 to 10 ml of autologous blood taken from a peripheral vein is injected into the lower calyx, and that clot makes a seal, and it prevents the fragments to accumulate in the lower calyx. So moving towards the endoscopic combined retrograde intrarenal surgery. This is the typical position used for the endoscopic combined renal surgery, and it was described in the Geldato modified spine Valdivia position (GMSV). And following that, there are various alternative positions that have been explored, and it includes prone split leg position or the ECRIS, and the Bart's flank free modified spine position, and the intermediate or fully spine position. So the benefit of ECRIS is that it reduces the number of tracks, excess tracks that are required for the stones that are occupying the multiple calyx. We can reduce the number of excess tracks with the ECRIS and precise kidney access by placing the ureteroscope tip in the targeted calyx. It helps guide the needle during both fluoroscopy guided and ultrasound guided procedures, thereby reducing the puncture time and improving the accuracy as well. As I said, for the large and the complex kidney stones, it improves stone-free rates, reduces number of auxiliary procedures, and it lowers down the complication rates as compared to the traditional PCI. So this is a video demonstration of percutaneous approach being performed for the metallic sheath and the miniature nephroscope.
So basically, while you're petrochloride immunoscope, you are visualizing the exact site of puncture, and you can decide that where exactly I will puncture and get maximum amount of stone removal from that side. This is, I guess, the nephroscope, the miniature nephroscope.
Yes, sir. So when the nephroscope is removed from the sheath, we can see the fragmented stones exiting through the sheath with the real-time ECRIS. And with the last video slide, this is the transport technique of real-time simultaneous ECRIS. The nephroscope can grasp the stone and the nephroscopic stone forceps is being used to remove the stone through the implant sheath.
So ECRIS is not a new technique. It is there for like decades now. But this flexible thing is made it more juicy. Like you can have now access to multiple calyxes via retrograde approach, and then you can choose your desired calyx. And this is good for the complex cases where you need multiple punctures or you need multiple sessions to get rid of the whole stone. So this is a great alternative.
Thank you.
So this was all about the flexible RIRS and ECRIS. Taking advantage of this forum, I would like that we should, as an institute, move towards getting hold of these armamentarium in our setup as well, because this is the demand of this era, and this segregated thing is now going towards the bad times, and this is the new in the urology which is being talked of the town these days, and things are moving very fast. Even with this technology, like while I was appearing for exam, we were discussing that for specifically about ureter access sheet, that what is the difference between the stone-free rate if you put a ureter access sheet and if you don't put a ureter access sheet. And now they have like to hold towards a new scenario that with ureter access sheet, what else you can do, like this real-time pressure monitoring, this lithoView, which is a newer access sheet, and now you can exactly monitor intra-renal pelvis, intra-pelvic pressure real time, and you can adjust your settings and things like this. So we need to like.
I would like to add two things that fortunately there are two ECRIS done in Pakistan and both done at SIUT. And unfortunately, we don't have access to the flexible sheet. If you talk about these stones, why use this modality? So it should be a very large stone, huge stone bulb with that bulb going into the pelvis. So every case cannot be done with this. We have seen a lot of patients in which you don't need two tracks, you need a single track, but it takes a lot of time, like 2 hours, and you're fragmenting that huge bulk in the pelvis with that branching. So in cases like that, we can do that. So it is not needed in every case, but yes, we have done 2 cases. It is doable, and the patient's huge bulk was completed in one go. But for that, we need a flexible URS.
So we need flexible URS, we need good fragmentation devices have that. The kind of fragmentation armamentarium we have is not coping up with the kind of stone burden we have. And most of the time we are like at the right place at the right time, we are visualizing the stone, but the amount of fluid we have already used and the kind of stone burden available with the patient is not possible with this like lithographs we have, and even the laser we have is like very low.
Again, 2 points.
Yes, sir.
As Harris said, again, 2 points. So I want to say about 2 points also. So one is whether this ureter access sheet is something of benefit for the removal of stone or passage of stone, maybe fragmentation of stone. In contrast to what actually is the value of ureter access sheet, and that is something which is known as intrarenal pressure. So it is basically the intrarenal pressure, and that has to be clear in everybody's mind that whether it is exempt or not, it is the physics and the hydrodynamics which is behind that ureter access sheet. So when you put in a ureter access sheet and you use a lot of water for irrigation purpose so that your vision is clear and you target your instrument to the right position, it is just because of the reason that more volumes of fluid is going in, and if there is nothing that can reduce pressure, so the pressure goes on and the channels will open up, and those channels are actually the gates, and these are the pyelovenous and the lymphatic channels. So in order to do away with that thing, the ureter access sheet has got its value more than fragment or passage of fragment. So that should be clear. The second point is, whenever you want to place in the ureter access sheet, the internal diameter of the ureter should be more than the external diameter of the ureter access sheet. Meaning to say, it should not fit snugly into the ureter. Otherwise, it will cause havoc. Meaning to say, when you remove the ureter access sheet, it will cause damage to the internal wall of the ureter. So उसका जो साइज है वो डिस्पैरिटी आना चाहिए, वो छोटा साइज होना चाहिए यूरेटर एक्सेस शीट का, और यूरेटर का जो है वो बड़ा होना चाहिए. The second point of आपका था the wish that we all have, and that wish is carried on from generation to generation. At least what I can say from my generation, and that is a phasing out generation, and your generation is coming in, is something which is known as whatever the policy makers are doing. Actually, we are disjointed. What we can this is to continue discussion, to continue discussing some of the basic principles of laser therapy. Come what may, what happens is कल को आ जाता है तो आपको इस्तेमाल करना तो आएगा ना. So you must be ready to accept the principles as well as the application of laser therapy.
So thank you everyone